Welcome back to Red, White, and Green. I'm your host, Nathan Smith. Today, we're tackling a question that comes up constantly and usually in a very emotionally loaded way. Does cannabis actually help with PTSD? Or are we just repeating stories we've heard online? And if it does help some people, what does the science say about who it helps, for which symptoms, and at what cost? This episode is about separating myth from medical evidence, not to shame anyone's experience, and not to hype a miracle cure, just to get clear on what we know, what we don't, and what researchers are trying to figure out right now in clinical trials, especially trials looking at high THC flower for PTSD symptoms like nightmares, insomnia, and hypervigilance. To do that, I'm joined by two guests who live in the world of data, protocols, and outcomes. Dr. Elena Ramirez is a clinical researcher involved in PTSD treatment studies. And Dr. Jordan Lee is a neuroscientist who studies cannabinoids, sleep, and fear learning.
Glad to be here. And I appreciate the framing, because PTSD isn't an abstract topic for people. It's personal, and it's often urgent.
Same here. Cannabis conversations tend to collapse into it's harmless versus it's dangerous, and neither extreme helps patients or clinicians.
Let's start with the basic confusion point. People say, weed helps my PTSD, but PTSD isn't just one thing. What are the main symptom clusters researchers look at?
Clinically, we're usually thinking about intrusive symptoms like nightmares or flashbacks, avoidance, negative mood and cognition changes, and hyperarousal, so things like being on edge, irritability, sleep disruption, and exaggerated startle. Sleep is huge. Many patients come in because they're not sleeping, and everything else gets worse when sleep collapses.
So when someone says cannabis works, it might mean it helps them fall asleep, or it might mean their nightmares change, or it might mean they feel less keyed up. Those are different outcomes.
Exactly. And research has to be specific. Which symptom, what severity, what time frame, and what are the trade-offs?
Okay, myth number one. There's tons of proof cannabis treats PTSD. How would you both respond?
There's a lot of interest and a lot of self-report, but that's not the same as proof. Observational studies can show associations, but they can't reliably tell us causation, especially because people with worse symptoms may be more likely to use cannabis in the first place.
And PTSD trials are hard. You need careful screening, stable dosing, monitoring for adverse effects, and a way to keep expectations from driving outcomes. When trials are done well, the results can be mixed. Sometimes you see benefit for a subset of symptoms or a subset of participants, sometimes not. And sometimes you see benefit early that doesn't hold over time.
Let's zoom into the kind of trial listeners may have heard about. Studies looking at high THC flower for PTSD. People might assume high THC automatically means stronger medicine. Is it that simple?
Not really. THC is one part of the picture. It's psychoactive and it can reduce anxiety for some people at some doses, but it can also increase anxiety, paranoia, and heart rate, especially at higher doses or in newer users. Plus, cannabis contains many cannabinoids and terpenes that may shape the experience, though the science on terpenes is much less definitive than marketing suggests. I'm glad you said marketing. Because strain selection gets treated like a personality quiz. People will say, this strain is for trauma, or this one is for nightmares. Dr. Ramirez, in trials, how do you even approach strain selection?
In a clinical trial, you can't rely on strain names. You need chemical characterization. What's the THC percentage? What's the CBD content? What's the delivery method? Then you standardize as much as possible so you can interpret results. Outside a trial, strain names vary by grower and batch. Even when labels list THC and CBD, potency and actual content can differ. That makes real-world selection messy.
So when someone says, blue something worked for my nightmares, it might not translate to the next person, or even to the same person next month with a different batch.
Right. What they experienced is real. But we can't assume the label guarantees the same product or the same effect.
Let's talk specifically about nightmares and sleep. This is probably the number one reason people with PTSD experiment with cannabis. What does the science say about cannabis and sleep architecture?
THC can make some people feel sleepy and may reduce sleep onset time short-term. It can also alter REM sleep, which is tied to dreaming. Some people report fewer nightmares. But there's a catch: if REM is suppressed, you may get rebound vivid dreams when you stop. And with regular use, tolerance can develop, meaning you may need more to get the same effect, which raises the risk of side effects.
That rebound effect is something people don't always hear about. They'll just hear, "It kills nightmares." And then when they take a break, the dreams come back in a big way.
Exactly. Also, sleep isn't just hours asleep. We care about sleep quality, next-day functioning, mood, and memory. If a product helps you fall asleep but leaves you foggy, unmotivated, or emotionally blunted the next day, that matters.
Now let's hit a tough nuance. PTSD treatment often includes trauma-focused therapy, approaches where you actually engage with traumatic memories in a structured and supported way. Some people worry cannabis might interfere with that process. Is that a real concern?
It can be, depending on how it's used. If cannabis is used primarily to avoid distressing thoughts and feelings, it might reinforce avoidance, which is a core feature of PTSD. Many effective therapies aim to reduce avoidance over time. That doesn't mean cannabis is automatically incompatible with therapy, but it means we need to evaluate function. Is it helping you sleep so you can do therapy, or is it keeping you from processing anything?
From a learning and memory perspective, we also consider how cannabinoids influence fear extinction, the process of learning that a cue is no longer dangerous. There's intriguing preclinical research suggesting the endocannabinoid system plays a role in extinction learning. But translating that into smoke this strain before therapy and it'll cure trauma is a leap. Dose, timing, and individual differences matter.
So it's not either it blocks healing or it guarantees healing. It's more like it can support or undermine progress depending on timing, dose, and intent.
That's a good way to put it.
Let's talk about dosing and delivery method. Because in casual conversations, people gloss over it. A person using a little at night for sleep is different from someone using throughout the day. And the method, smoking versus vaping versus edibles, changes the experience.
Right. Inhalation has a faster onset and easier titration. You feel effects quickly and can stop. Edibles kick in later and last longer, which increases the risk of accidentally taking too much. For PTSD symptoms like panic, that timing matters. If someone takes an edible thinking it's not working, takes more, and then gets hit with a stronger than expected effect, that can be terrifying.
And when we say too much, what does that look like clinically?
Acute effects can include anxiety, panic, racing heart, paranoia, dizziness, nausea, impaired coordination. For people with trauma histories, feeling out of control can itself be triggering. So patient education is crucial. Start low, go slow, and don't experiment in an unsafe environment.
Myth number 2, CBD is always a safe option. True, false, or complicated?
Complicated. CBD is not intoxicating in the same way as THC, and it may reduce anxiety for some people, but products vary widely in quality. CBD can also interact with other medications by affecting liver enzymes. So safe depends on dose, purity, and what else you're taking.
And some CBD products contain more THC than expected. That can be a big deal for someone sensitive to THC, or anyone subject to drug testing.
Let's go into that. The real-world issues that don't always show up in idealized discussions. One is dependence and cannabis use disorder. How should listeners think about that risk in the PTSD context?
PTSD increases risk for substance use problems in general, often because people are trying to manage symptoms quickly. With cannabis, dependence risk is real, especially with frequent high THC use. Signs include increasing tolerance, difficulty cutting down, using more than intended, spending a lot of time using or recovering, and continued use despite negative impacts on relationships, work, or mental health.
And someone might say, but it's not like opioids. And sure, it's different, but different doesn't mean risk-free.
Exactly. It's a spectrum. Many people use cannabis without developing a disorder, but the risk rises with potency, frequency, and starting young. Also, if cannabis is the only coping tool, that's when it can become sticky.
Another reality. Some people have co-occurring conditions: depression, anxiety disorders, bipolar disorder, psychosis risk, ADHD. How does that change the calculus?
It's a major factor. High THC products can worsen psychosis risk in vulnerable individuals. For bipolar disorder, cannabis can sometimes destabilize mood. If someone has significant depression, cannabis might temporarily numb feelings but potentially reduce motivation or increase isolation. This is why clinical oversight matters for some patients.
Let's bring it back to trials. When researchers test something like high THC flower for PTSD, what outcomes are they measuring beyond "did you feel better"?
We use standardized PTSD symptom scales, sleep measures, anxiety and depression scales, quality of life, functional outcomes like work and relationships, and adverse event tracking. We also look at how much people actually use, whether they escalate dose, and whether benefits persist weeks or months later.
And strain selection for specific symptoms: nightmares, insomnia, trauma-related anxiety. How close are we to having evidence-based guidance?
We're not at the point where we can say, use strain X for nightmares. What we can do is talk about ratios in pharmacology, THC dominant versus CBD dominant, or balanced profiles, and how those might influence anxiety, sleep, and side effects. But even that is probabilistic. Two people can take the same product and have opposite experiences.
So if a listener is hearing this and thinking, okay, but I'm just trying to sleep, I'm exhausted, what am I supposed to do with all this nuance? What would you say?
I'd say, start with a clear goal and a plan. If your goal is fewer nightmares or better sleep, track it. Write down bedtime, waking time, nightmares, next day functioning, dose, and product type. And don't ignore foundational sleep and PTSD treatments. Evidence-based therapy for PTSD and targeted treatments for nightmares and insomnia exist. Cannabis might be one tool, but it shouldn't be the only tool.
And if someone does try cannabis, be cautious with high THC, especially if you're sensitive to anxiety. Consider lower doses, avoid escalating quickly, and be mindful about timing. Also, be honest about whether it's helping your life get bigger, more connected, more functional, or smaller.
That framing is powerful. Is your world expanding or shrinking? Let's do a rapid-fire myth check. Myth: if cannabis helps me sleep, it must be treating my PTSD.
Not necessarily. Improving sleep can reduce symptom intensity, but it doesn't automatically resolve trauma-related patterns like avoidance or intrusive memories. Sleep relief is meaningful, but it's not the full diagnosis.
Myth: more THC means more benefit.
Often false. Higher THC increases the likelihood of adverse effects and tolerance. Therapeutic effect, if present, may happen at lower doses for many people.
Myth: if it's natural, it can't hurt me.
Natural doesn't equal safe. Cannabis can have side effects, interact with mental health conditions, and increase risk of dependence.
Before we wrap, I want to ask each of you, what's one question you wish every headline about cannabis and PTSD would answer?
I want headlines to specify what product, what dose, and for which symptom. Cannabis helps PTSD is too vague to be meaningful.
I want them to say, for whom, and at what cost. Benefit without discussing risks and alternatives isn't informed care.
So here's the take-home. The clinical science is still developing. Some people report real relief, especially around sleep and nightmares. But that doesn't automatically generalize, and it doesn't come without potential downsides. Strain names aren't evidence. Potency isn't a plan. And if you're exploring cannabis for PTSD, the smartest approach is structured. Set a goal, track outcomes, be cautious with dosing, and keep evidence-based PTSD care in the picture. Dr. Ramirez, Dr. Lee, thank you for helping us stay grounded in reality while still respecting the lived experiences people bring to this.
Thanks for having us. This kind of careful conversation is what patients deserve.
Appreciate it. The best outcomes usually come from curiosity plus caution.
And to everyone listening, if you're struggling with PTSD symptoms, you don't have to DIY this alone. Talk with a qualified clinician if you can, especially if you have other mental health conditions or you're on medications. We'll be back next time with another topic where the internet has opinions. and the data has nuance. Thank you for joining Red, White, and Green. And again, I'm your host, Nathan Smith. Until next time, stay green, my friends.